Good evening. Now we'll move to Pfizer Symposium. Can you see my slides?
Yes, Mr. Mohammed.
Okay. Okay. I will start my presentation. Paving the way in the clinic. Real-world outcome with CDK4 and 6 inhibitor treatment. CDK4 and 6 in ER-positive breast cancer. The growth of hormone-positive breast cancer is dependent on cyclin D1, a direct transcription target of ER. Cyclin D1 activates CDK4 and 6, resulting in G1S phase transition entry into the cell cycle. Resistance to endocrine therapy is associated with continued dependence on cyclin D1 and CDK4 and 6. CDK4 and 6 are the convergence point for the ER and other cell growth signals. CDK4 and 6 control cell cycle progression from G1 to S phase by regulating the activity of retinoblastoma gene. Synthesis of D-type cyclins, D1, 2, and 3, an association with CDK4 and 6 is initiated in response to mitogenic signaling pathway. Then, active cyclin D, CDK4 and 6 phosphorylates retinoblastoma, decoupling retinoblastoma for E2F and allowing transcription of genes required for cell cycle progression. Retinoblastoma inhibits E2F mediated transcription by binding to and sequestering E2F. Then E2F activates transcription of genes necessary for S phase entry and cell cycle progression. Combining targeted anti-estrogen therapy to overcome resistance in hormone HR-positive advanced breast cancer. Around 30% of hormone receptor-positive metastatic breast cancer are de novo resistant to endocrine therapy, with most developing acquired resistance. Mechanism of resistance may include loss or alteration of ER expression, overexpression, activation of growth factor receptors, or activation of downstream signal transduction pathways. Cycling E as a driver of CDK4 and 6 inhibitor resistance, classical G1 S phase transition, CDK4 and 6 inhibitor sensitive, non-classical G1 S phase transition, CDK4 and 6 inhibitor insensitive. Summary of data on biomarkers of resistance to CDK4 and 6 inhibitors, de novo resistance, preclinical and clinical data cycling E associated with de novo CDK4 and 6 inhibitor resistance, fibroblast growth factor receptor amplification associated with resistance to endocrine therapy and CDK4 and 6 inhibition, acquired resistance according to Paloma 3 trial, retinoblastoma 1 mutation around 4.7%, frequent acquisition of new PIK3, 3A, and ESR1 mutation. 6% of patients with no detectable PIK3, 3A mutation acquired new PIK3, 3A mutation by end of therapy. Positive selection of Y537S at end of therapy, ligand binding domain mutation, highly resistant to fulvestrant. The spectrum of metastatic breast cancer virulent, rapid development of metastasis, shorter disease-free interval, extensive visceral involvement, resistance to endocrine therapy. Indolent course, long disease-free interval, later occurrence of metastasis, bone and soft tissue disease sensitive to endocrine therapy. Treatment decision in metastatic breast cancer depends on previous therapy, disease-free interval, patient preference, side effects, ER and PR status, HER2 status, patient symptoms, and visceral versus non-visceral metastasis. Here is the landscape or evolving treatment landscape of hormone receptor positive advanced metastatic breast cancer. And as we see here, in the past 7 years, the approval of targeted therapy plus endocrine therapy, fulvestrant, everolimus, mTOR inhibitor, palbociclib was the first CDK4 to be approved, then ribociclib and abemaciclib, and alpelisib recently approved for PI3Ka inhibitor. CDK4 and 6 inhibitors are oral drugs. The dose of palbociclib is 125 once daily, ribociclib 600 milligram once daily. Abemaciclib, if monotherapy, 200 milligram twice daily. If combo with endocrine therapy, 150 milligram twice daily. Schedule for palbo and ribo is 3 weeks on, 1 week off. For abemaciclib is continuous. The half-life of palbociclib is 27 hours. Ribociclib is 32.6. Abemaciclib 17 to 38 hours. Here is the different trials with CDK4 inhibitors in first-line trials: Paloma 1, Paloma 2, Mona Lisa 2, Monarch 3, Mona Lisa 7, Mona Lisa 3. And the best hazard ratio was for palbociclib plus letrozole according to the Paloma trial with a hazard ratio of 0.49. All others were above 0.5. And here are the post-AI trials with the combination with fulvestrant, Paloma 3, Monarch 2, Mona Lisa 3, and Monarch 1. And what I want to highlight, the hazard ratio for Paloma 3 is 0.46. And the population of this trial was in heavily pre-treated patients. And patients have received previous endocrine therapy and even chemotherapy. So the spectrum of selection of patients in Paloma 3 was in heavily pre-treated patients. Current indication for CDK4 and 6 inhibitor for the treatment in the United States and first-line endocrine-based therapy with an AI post-menopausal woman, the same for ribociclib and palbociclib. Then second line with fulvestrant after disease progression following endocrine therapy for abemaciclib, monotherapy for adult patients after progression following endocrine therapy and prior chemotherapy. Ribociclib, first-line endocrine-based therapy with AI, first-line endocrine-based therapy with fulvestrant post-menopausal woman, second line with fulvestrant after disease progression following endocrine therapy. While in palbociclib, first line endocrine-based therapy with an AI post-menopausal woman, second line with fulvestrant after disease progression following endocrine therapy. And nearly the same in Europe. Are all CDK4 and 6 created equal? Paloma 3 subgroup analysis suggests overall survival benefit from palbociclib limited to endocrine sensitive tumors. Monarch 2 and 3 pooled analysis showed a larger absolute benefit of abemaciclib in endocrine insensitive groups, example, liver metastasis compared with low risk groups, bone only disease, long treatment-free interval. Hypothesis, there exists difference in efficacy of CDK4 and 6 inhibitors based on the degree of endocrine sensitivity, and biomarkers of response differ by type of CDK4 and 6 inhibitor. Treatment of luminal ER-positive metastatic breast cancer in 2019, understanding endocrine resistance, genomic change in ER-positive advanced breast cancer, common pathways to future therapeutic intervention. Clinical benefit of CDK4 and 6 inhibitors, significant improvement in progression-free survival in both first-line and second-line setting, now standard of care. Which subgroups of patients derive the most benefit? When best to use CDK4 and 6 inhibitor optimal sequencing? Impact on overall survival, clinical data for palbociclib, Paloma 3, ribociclib, Mona Lisa 7, Mona Lisa 3, abemaciclib, Monarch 2. Implication for clinical management, translational research and biomarker for response, clonal evolution and driver mutation in ER-positive metastatic breast cancer, circulating DNA and biopsies in metastatic studies of CDK4 and 6 inhibitor. This is the ABC4 guidelines for postmenopausal women. If our patient is ER-positive, HER2 negative, advanced breast cancer, postmenopausal. If there is visceral crisis, the preferred choice is chemotherapy. If no visceral crisis, endocrine therapy is the preferred choice. First line, AI or tamoxifen or fulvestrant, AI plus CDK4 and 6 inhibitor, AI plus everolimus for some women with progressive disease after non-steroidal aromatase inhibitors. Second line, different aromatase inhibitor plus or minus everolimus, fulvestrant plus or minus CDK4 and 6 inhibitor, migestrol acetate or estradiol. And if the patient progress or has develops visceral crisis, the choice is chemotherapy. This is the NCN guidelines with the same guidelines as the ABC4. Adverse events of CDK4 and 6 inhibitors, we have diarrhea for abemaciclib, palbociclib, and ribociclib, hepatobiliary toxicity for abemaciclib and ribociclib, QT prolongation specific for ribociclib, neutropenia for all of them, abemaciclib, palbociclib, ribociclib, venous thromboembolic events, abemaciclib, and recently FDA released a warning for CDK4 and 6, which is interstitial lung disease and pneumonitis for abemaciclib, palbociclib, ribociclib, which is around 1% in the Western population and around 5% in Japanese patients. Our topic, real-world data complement data from clinical trials. Real-world data add to the body of evidence and provide information that may aid in clinical practice, measure efficacy and safety of an intervention in a specific patient population, designed to show causality or cause of the cause of disease, utilize pre-specified protocol-defined uniformly assessed endpoints, randomize patients to treatment or comparator, conduct in a highly monitored, controlled environment. Measure effectiveness and safety of an intervention under real-world condition, but not causality and hypothesis generating. Assess patient-reported outcomes such as quality of life and satisfaction with therapy in real-world setting. provide insight into practice pattern across diverse clinical settings and geographics and in patients not necessarily included in clinical trials. Don't randomize patients, and bias may be introduced by describing patterns and lack of uniform assessment of outcome. Importance of real-world data in oncology: support active pharmacovigilance, develop external control arms, enable evidence generation based on pragmatic clinical trials, support randomized study design, expand clinical research to point of care, may help increase access to experimental therapies, increase patient participation in clinical trials. Why do we need real-world evidence? Because of limitation of clinical trial data, highly selected cohort of patients, selection bias due to barrier to access trial, race, ethnicity, age, limited comorbid condition, measurable or valuable disease, investigators' experience with use of drugs, long-term toxicity data needed. Clinical trial experience may not extrapolate to patients in community, difference in patients' characteristics, variation in the clinical use of agents, insurance and accessibility issues, difference in toxicity. Real-world data play an increasingly important role in expanding use of already approved medicine, like the approval of expanded indication based on predominantly on real-world data. FDA approved palbociclib plus endocrine therapy in men with hormone-positive, HER2-negative breast cancer. The approval is based on data from electronic health records and post-marketing reports of the real-world use of Ibrance in male patients sourced from 3 databases: IQVIA Insurance Database, Platirone Health Breast Cancer Database, and the Pfizer Global Safety Database. Real-world data can inform about the treatment pattern for hormone receptor-positive, HER2-negative breast cancer in the CDK era. As we see here, pre or before the approval of CDK4 and 6, the use of endocrine therapy was around 60%, and for chemotherapy it was 40%. But after the approval of CDK4 regimen, 52%, endocrine therapy alone 30%, and the decrease of chemotherapy use to 13% and other 5%. Overview of select real-world studies with palbociclib. We have the IRIS study in United States, Argentina, and Germany. Platirone analysis, it is a comparative study in the United States. Polaris prospective study in Canada and United States, and expanded access program in the United States. And the IRIS overview, it is a retrospective medical record review, multiple countries, North America, South America, and Europe. And as we see here, in the IRIS study, the median age was 65 for United States, 64 Argentina, 60 in Germany, and it was well balanced between many patients above half of the patients had visceral metastasis, and the rest was non-visceral. ASU performance was well represented. Again, as regarding the starting dose of palbociclib, 125 milligram per day was the majority, and then 100 milligram, and to a lesser extent 75 in the United States. In Argentina, most of the patients received 125 milligram. Again, in Germany, most of the patients received 125 milligram per day, which means the drug is well tolerable. As regarding dose adjustment, around 80% in the United States didn't need dose adjustment, and Argentina around 90% didn't need dose adjustment, and in Germany above 90% of patients didn't need dose adjustment. As regarding progression-free survival, at 24 months in the United States, palbociclib achieved a progression-free survival rate of 64.3. In Germany, at 12 months, 79.8. In Argentina, at 18 months, 80%. And in the palbociclib plus fulvestrant, it was not reached in Argentina at 12 months. And as regarding overall survival rates, United States at 24 months was 90.1, which is very high. And in Germany, it was not reached at 2 years. In Argentina, it was 89% at 18 months. And for palbociclib plus fulvestrant, it was not reached at 12 months. Here are a comparison between the reasons for discontinuation from real life from the IRIS study. And the other study was a prospective Platirone comparative data analysis. And what it showed the first real-world comparative effectiveness analysis of palbociclib plus letrozole versus letrozole alone as first-line therapy for hormone-positive, HER2-negative metastatic breast cancer. And the real-world progression-free survival for palbociclib plus letrozole was 24.5 months versus 17.1 for letrozole. And as regarding overall survival, and Unadjusted analysis, it was not reached for palbociclib plus letrozole, and it was for letrozole around 40.3. And for propensity score matching for overall survival, it was not reached for palbociclib plus letrozole, and it was 38.1 for letrozole alone. The Polaris palbociclib in in hormone positive advanced breast cancer, a multi-center prospective non-intervention study. This study tried to present or increase the spectrum of presentation of real-world data. And as we see here, the median age was around 64, and as regarding endocrine therapy partner, it was palbociclib plus AI 46%, and then palbociclib plus fulvestrant, palbociclib plus AI, palbociclib plus fulvestrant second line. Menopausal status was well presented, 76% of patients. Visceral versus non-visceral, non-visceral was 72, and ASU-ICOC performance 43% were performance still 0, and 43% had bone-only disease, and 57 bone-only plus other metastases. The starting dose of palbociclib and dose modification, most of the patients, palbociclib plus AI, palbociclib plus fulvestrant, have received around 90% of the patients have received over 125 milligram per day of the standard dose of palbociclib, and to a lesser extent 100 milligram. The adverse events, as we see a comparison between Polaris and Paloma 2 study, neutropenia in the Polaris was better. It was 35% versus 80%. The Paloma 2, leukopenia was better, 4 versus 39. Anemia was better, 19 versus 24. And the fatigue in real life was lesser than what we have seen in the Paloma 2 study. Effect of palbociclib in patients aged over 70 years of age, which is very important. And we have seen by assessing geriatric AIDS tool to assess frailty and functional status and the activities of daily life, we have seen that functional status was preserved in this elderly population receiving palbociclib. And another, the last one is the palbociclib expanded access program in the United States, measuring 3 distinct observation periods before enrollment in the expanded access program, treatment period palbociclib plus letrozole, and then the period after the expanded access program. And the expanded access program long-term follow-up selected outcomes have showed in real-world progression-free survival rate. It was the best for no prior lines, then second for one if the patient have received 1 prior line, and then second if the patient has received 2 lines before. And as regarding progression-free survival, what was very interesting at 12 months, that if the patient had received 1 prior line, the overall survival was better than no prior line, better than 2 prior line. But at 24, 71% of patients had overall survival rate, and 65 if received 1 prior line, and 35 if received 2 prior lines before. So sequence of CDK4 and 6 inhibitor across lines of therapy, we try to evaluate the real-world evidence of limited clinical activity of palbociclib combination after progression of everolimus. And as we see here, real-world study cohort and the clinical trial palbociclib plus fulvestrant cohort of Paloma 3, we've seen in real world that there is no benefit or little benefit in real life if the patients receive palbociclib after progression with everolimus. And on the other hand, real-world evidence of similar efficacy of everolimus-based therapy with or without prior exposure to CDK4 and 6 inhibitors. And as we see, as regarding progression-free survival, the median real-world progression-free survival prior CDK4 was 5.7. No prior CDK4, it was 5.6. At 1 year, it was prior CDK4 25.3%, and no prior CDK4, it was 27.9%. And overall survival, it was prior CDK4, it was 13.7, and no prior CDK4 6, it was 11.4. And at 1 year overall survival rate, it was for prior CDK4 56 versus 43 for no prior CDK4. First line CDK4 6 treatment outcomes in older women. It was also evaluated in US Food and Drug Administration pooled analysis of outcomes of older women with hormone receptor positive metastatic breast cancer treated with CDK4/6 inhibitor as initial endocrine based therapy. And here is the pooled retrospective subgroup analysis. And as we see here, for all the baseline characteristics are well balanced: visceral bone metastasis, neoadjuvant chemotherapy, neoadjuvant endocrine therapy, and stage 4 disease. And The participants, we had patients less than 65 years, which were the major population, and then 65 to 74, and then we had also some patients above 75. And what was interesting here that the older the age, the more the dose reduction and interruption. The older the age, we had the more discontinuation of treatment, and the older the age, serious adverse events. But even in patients with 65 to 69 years, there was benefit with CDK4 and 6 inhibitor, and even some patients over 70 years had a manageable toxicity profile. This is a comparison between highly pretreated patients with ER positive and HER2 negative breast cancer in 2 centers in Belgium and 1 center in Croatia, which showed the poor outcome if patients had received many lines before, which notes we have to start CDK4/6 palbociclib early. And cross-study comparison need to be taken with caution to the difference in study design. So at the end, real-world insights remarks, FDA analysis includes older patients, which was not represented in the clinical trials. Ethnicity issue is important, differential toxicity of agents in different ethnic groups. Retrospective analysis have advantages and disadvantages. Real-world evidence collected in a prospective manner will provide additional insights. Clinical data are limited. Example, narrow patient population versus patient treated in clinics. Reported real-world evidence with CDK4/6 inhibitors have demonstrated similar survival outcomes and adverse events profiles to those observed in the pivotal trials. Larger studies in the community settings are expected to provide additional real-world evidence. Treatment pattern in older and younger patients compared with those enrolled in the pivotal trials. How might real-world evidence involving CDK4 and 6 inhibitors benefit patients with hormone receptor-positive metastatic breast cancer in clinical trials? Clinical trials provide fairly consistent evidence regarding benefits of CDK4 and 6 inhibitors in first or second line treatment of women with hormone positive HER2 negative metastatic breast cancer. Real world evidence can be helpful in providing treatment recommendation for individual women. Treatment setting, newly diagnosed or recurrent, and time to recurrence are important variables. Clinical consideration, prognosis, extent of metastatic disease, location of metastasis, whether the patient is symptomatic, prior therapy, line of therapy, tumor characteristics, recommended starting dose modification, expected adverse events, required monitoring, treatment-related symptoms, laboratory abnormalities, grade 3 and 4 neutropenia. Dose modifications are not uncommon, 20% to 40% chance of dose modification, at times more than once. Some clinician reports starting with a slightly lower dose, treatment still likely to provide benefit. Further direction, CDK inhibitor may benefit women as third or fourth line of treatment. Expanded access studied with abemaciclib and palbociclib, TBC R035 palbociclib with fulvestrant or tamoxifen in previously treated patients with hormone-positive metastatic breast cancer. Correlation of response by those with retinoblastoma and Ki-67 could inform palbociclib dosing and reduce toxicity. Experience in diverse population or in different parts of the world. Real-world clinical outcomes of palbociclib in hormone-positive metastatic breast cancer. Retrospective single institution review, 411 patients with hormone-positive metastatic breast cancer treated with palbociclib plus either an AI or fulvestrant between 2015 and 2017. Primary outcome, progression-free survival assessed by clinician based on radiologic and or clinical criteria. Median follow-up is 10.2 months. Real-world clinical outcomes, estimated progression-free survival, palbociclib plus fulvestrant 10.3 months, palbociclib plus letrozole 8.9 months. Most 65% patients received palbociclib plus letrozole in second line or later. Patients who received it in the first line had estimated progression-free survival of 15.1 months. Palbociclib dose was reduced due to toxicity, most commonly neutropenia, in 27% of patients, permanently discontinued in only 7%. In hormone-positive metastatic breast cancer, patient non-clinical trial setting, estimated progression-free survival on palbociclib by fulvestrant comparable to PALOMA-3, observed progression-free survival with palbociclib letrozole as first-line therapy shorter than in PALOMA-2. Palbociclib was well-tolerated, manageable toxicity, low rate of drug discontinuation. My last slide. Real-world data adds to the body of evidence for therapeutic agents, expand use into the patient groups not typically represented in clinical trials. Example, elderly. Palbociclib has a large, broadly representative evidence base with multiple real-world studies ongoing around the world. Real-world effectiveness outcomes with palbociclib complement what has been seen demonstrated in clinical trials. Dosing and frequency of dose adjustment of palbociclib in real-world studies are as expected based on clinical trial experience. Real-world studies of palbociclib and other CDK4 and 6 inhibitors are beginning to elucidate sequencing pattern in clinical practice. Thank you for your attention. Thank you. Thank you for your attention, and due to